Annie, what your experience is, I've seen a lot of overlap syndrome with
Yeah, I've
autoimmune
seen
and
a decent
PSC.
amount of that.
Yeah. So that's really a separate issue altogether and more complicated. So we're going to deal with the, guess we call it the garden variety autoimmune hepatitis today. So what are we talking about? And you notice the reference is Dr. Shaya down at the bottom here. He's probably, historically the #1 investigator for this disorder with numerous publications. I believe he was out of Mayo Clinic. So autoimmune hepatitis is a chronic hepatocellular injury with an unclear etiology, as most autoimmune syndromes are. It's characterized by a lymphoplasmacytic infiltrate, and we'll show that as well. With interface hepatitis, you'll see the terms interface hepatitis and piecemeal necrosis used interchangeably. They're the same thing. It can lead to lobular or panacinar necrosis, or it can just be associated with portal inflammation with minimal necrosis. All of these patients have a predominant elevation in their aminotransferase levels. The type of autoimmune hepatitis is characterized by the presence of specific autoantibodies as well as hypergammaglobulinemia of varying degrees, which is again seen in virtually all patients. And at the end of the day, it often is a diagnosis of exclusion, although we tend to come to that diagnosis much more rapidly when we know what we're looking for and how to look for it. The other diseases that we need to differentiate AIH from include obviously the viral hepatitis, and we'll be talking about both HBV and HCV in separate lectures as we move on with the year. Metabolic associated chronic liver disease, previously known as NAFLD. Drug-induced hepatotoxicity, and we have a separate lecture on drug-induced liver injury, which I'll be giving later on. Wilson disease, another separate lecture. And then we've already talked about alpha-1 antitrypsin deficiency. I will leave a discussion of PSC to Dr. Levine because I'm sure she will touch upon it when she talks about inflammatory bowel disease. That's the setting that we see PSC. And again, it can be a confounding problem because overlap syndrome is fairly common in patients with IBD, where there are features both of autoimmune hepatitis and primary sclerosing cholangitis. The other disorders which are grayed out, we really don't see in the pediatric age group. Overall, the incidence of autoimmune hepatitis is about 2 cases per 100,000 persons per year. Its prevalence is about 17 per 100,000. Interestingly, females account for 70% of cases. And again, I would probably exclude the overlap syndrome because I think that that's a more equal gender distribution in that. And 50% are less than 40 years of age. As a cause of chronic liver disease, it's up to 1/4 of patients, and it accounts for somewhere between 3 and 6% of liver transplants in Europe and the United States. So the natural history can be considered as a function of whether one has severe disease, moderate disease, or is relatively mild or asymptomatic. Severe disease, untreated, and how do we define severe disease? It's an AST greater than 10 times the upper limit of normal, or an AST greater than 5 times the upper limit of normal, plus a IgG greater than twice the upper limit of normal. So if you don't treat these patients, 40% will die within 6 months of diagnosis. 40% of the survivors develop cirrhosis. 54% of cirrhotics develop varices within 2 years. and 20% of patients with varices will bleed. So obviously, this is a group where non-treatment is never going to be an option. What are the poor prognostic factors without treatment? Again, liver chemistries, ALT greater than 10 times or AST greater than 5 times, as I showed on the previous slide, with a greater than twofold elevation in your IgG. And in those patients, the risk of cirrhosis is great and has a 90% mortality at 10 years. Patients with bridging necrosis, that is, you see inflammation that bridges between portal areas, obviously leading to destruction of the hepatocyte, and where you destroy cells, you replace them with collagen. So this is called bridging necrosis, ultimately bridging fibrosis, ultimately cirrhosis. So those patients who already have bridging necrosis, 82%, not unexpectedly, will develop cirrhosis within 5 years, and there's a 45% mortality at 5 years. Again, this is without treatment. What we know about autoimmune hepatitis is that it is associated with specific HLA genotypes, and the genotypes can be differentiated between type 1 and type 2 autoimmune, and we'll talk about these two types. And it's the DRB1 species of HLA genome, and there are specific phenotypes within the DRB1 that are characterized by both type 1 and type 2. And I'll have something more to say about that as we go on. First-degree relatives of patients with autoimmune hepatitis often demonstrate characteristics of the disease without the disease itself. They may elaborate autoantibodies, and they may also show some level of hypergammaglobulinemia without overt disease. So genetic factors certainly play a major role in AIH. These genetic factors will determine how the antigen is presented to immunocytes, leading to immunocyte activation. As I mentioned, DRB1 is the HLA subtype, and that encodes for a specific major histocompatibility antigen, which actually presents the antigen to T cells and leads to immune activation. Triggering factors are thought to lead to the ultimate syndrome, and they can be infections, medications, toxins, or other molecules which may be absorbed via the GI tract and leading to what we call molecular mimicry, something that looks like self but isn't, and leads to autoimmune activation. HLA-DRB1, again, is a class 2 molecule. It's anchored in the cell membrane of the antigen-presenting cells. And these include B lymphocytes, dendritic cells, and macrophages. HLA-DRB1 plays a central role in adaptive immune regulation, and it presents peptides ultimately to T helper cells. So when you develop autoimmune hepatitis, you are reacting against self. So you have an autoantigenic peptide, which is processed by the antigen-presenting cell. This is recognized, this complex of antigen and the MHC2 complex is recognized by uncommitted lymphocytes of the species CD4. This results in a cytokine release from both Th1 and Th2 CD4 cells. And again, this subsequently leads to proliferation of CD8 cells, the same CD8 cells we see in celiac disease, for example. and leads to a proliferation of both B and T cells, which react against self. And this is a depiction of what happens. This is the antigen-presenting cell, and here you have the MHC class II. Here you have the peptide antigen, the T cell receptor on the CD4 cell. This is all activated, leading to the production of pro-inflammatory cytokines. These antibodies are generally directed against specific self-proteins. In type 1, this is the asialoglycoprotein receptor. And there's a suppressor T cell, a defect. Suppressor T cells hold down, or regulatory T cells hold down the inflammatory response. If there's a defect, you have an overproliferation of natural killer cells. And these lead to an antigen-antibody complex, activated killer cells, as well as pro-inflammatory cytokines lead to hepatocellular destruction. And so again, this involves both a humoral and cell-mediated immunity. The cytokines that are released include IL-12 and IL-2, both potent pro-inflammatory cytokines. And again, we have this display of MHC class II antigens, which present an altered peptide that is recognized as self. This results in the production of CD8 T helper cells, which lead to the destruction of hepatocytes. The autoantibodies in autoimmune hepatitis include, and you're, I'm sure, all familiar with this, anti-nuclear antibody, anti-smooth muscle antibody, anti-liver kidney microsomal antibody, and anti-soluble liver antigen. What is the meaning of this? These are all antibodies directed at self-proteins. IgG is typically elevated in these patients in type 1 greater than in type 2. We'll have more to say about that. And the histology includes, again, interface hepatitis or piecemeal necrosis with a marked lymphocytic or lymphoplasmacytic infiltrate and the formation of hepatocellular rosetting. And I'll show you some slides that represent that. And again, one needs to, of course, exclude other viral hepatitis syndromes, particularly Hep B and Hep C. So what about the types? The type that you are most likely to see in most patients will be type 1. Type 1 hepatitis will appear at all ages from infancy to the elderly. Again, females account for 78% of patients. The autoantigen that is presented to the antigen by the antigen-presenting cells is the asialoglycoprotein receptor, which is present on the surface of all cells. The autoantibodies are ANA, anti-smooth muscle, but you also get P-ANCA, anti-actin, and anti-soluble liver antigen and liver pancreas antigen. So all of these can be used to confirm a diagnosis of type 1 autoimmune hepatitis. The HLA-DRB subtypes are shown here. These you can read about. You're not going to be asked on the boards to give them back. And what is also interesting, much like celiac disease, patients with autoimmune disease tend to have other autoimmune diseases for obvious reasons. And so the extrahepatic autoimmune diseases in patients with AIH are up to 40% of patients. And these patients with type 1 will have marked elevations in their gamma globulin. So here we have the, depending upon what your subtype of your HLA-DRB1 is, that's going to determine sort of the characteristic of the patient. With this genotype, HLA genotype, tend to be younger females with severe disease. They tend to have a high relapse rate. They may fail therapy with steroids, and they're most likely to require liver transplantation. So your HLA subtype does play a major role in determining your prognosis. If you're HLA-DR4, these are older females with milder disease. They tend to be more steroid responsive, and they have a higher frequency of extrahepatic autoimmune diseases. I have not seen, I can't remember seeing a patient who was not steroid responsive, although we see many patients who are steroid responsive and quickly relapse when you withdraw steroids. Type 2 tends, again, to be in children, somewhat older, adolescents primarily. Females are 90%. The autoantigen is part of the cytochrome P450 system. The autoantibody is LKM1, anti-liver kidney microsomal 1. So one of the important things for the fellows that you have to know is that you can differentiate type 1 from type 2 autoimmune hepatitis based on the autoantibodies. Type 2 will be anti-LKM, type 1 will be anti-ANA, will be the ANA and the anti-smooth muscle. These patients have a 40% likelihood of extrahepatic autoimmune disease. Their gamma globulins tend to be milder. However, they tend to be more severe. So don't let the lower level of gamma globulin fool you. Patients with type 2 tend to have more severe disease histopathologically. The clinical manifestations are many, and they are really characterized. And some of these clinical manifestations are a consequence of therapy as well. But fatigue, jaundice, right upper quadrant pain, anorexia, these patients will generally come to you because of fatigue and the onset of jaundice. Later on, of course, they can develop all of the problems that many patients with chronic liver disease can develop. So if you look overall at clinical manifestations with AIH over all subtypes, fatigue and jaundice head the list. So I don't think I've seen a patient who did not have those two. But there you can see the other problems that the patients will present with. Hepatomegaly is extremely common, again. Splenomegaly really is going to depend upon the length of time the patient has had the disease, because splenomegaly is going to be the consequence of portal hypertension secondary to cirrhosis. The laboratory features: 100% of AST elevations, virtually 100% hypergammaglobulinemia, characterized by elevated IgG. Alkaline phosphatase is not a reliable indicator, because only a third of them will have an alk phos that's greater than twofold normal. And when you're dealing with a growing adolescent, that can even be more confusing. In terms of serological markers, 100% with type 1 or type 2 will have either anti-smooth muscle, anti-nuclear, or anti-LKM, again, depending upon the subtype. And there you see the frequency of the other autoantibodies. And type 1 will have perinuclear p-ANCA, and type 2 will have an anti-liver cytosol antibody. But again, really all you need for the vast majority of patients are the anti-smooth muscle, the ANA, or the anti-LKM, and those are really the only ones, fellows, that you'll be presented with when you see something like this on the boards. Of course, with any chronic liver disease that's associated with regenerative nodules, so hepatocellular destruction, hepatocellular carcinoma, certainly becomes a problem that has to be monitored in these patients long term. In terms of the extrahepatic autoimmune disease that we talked about, it's a wide variety: autoimmune thyroiditis, Graves' disease, a variety of connective tissue disorders, IBD, again, in your patient population, that is the one autoimmune disease that you are most likely to encounter. But all of these diseases that are shown here have been associated with autoimmune hepatitis. The liver chemistry tests that you're going to obtain include the aminotransferases. These are rarely above 1,000, but we've all seen them over 1,000, most commonly less than 500 units per liter. Hyperbilirubinemia can be a part of the presentation. It can also indicate severe acute decompensation in end-stage liver disease. And again, remember that the alk phos is generally less than twice the upper limit of normal. The serologies, again, I showed you, I'm telling you again that these are the serologies you're going to look at. ANA, anti-smooth muscle, p-ANCA, anti-actin, and the anti-sialoglycoprotein receptor. Type 2 is primarily anti-LKM. They all will have elevated gamma globulin. And type 2, interestingly, is characterized by a low level of IgA. So here again are the subclassifications. Type 3, which is shown here, is something you really don't have to know about. It is actually a form of type 1 that occurs in older subjects. So we'll forget about that. And here again are the type 1 and type 2. The type 2, again, primarily in children up to adolescence. Type 1 has a bimodal presentation, either in the second decade of life or in the fourth or fifth or sixth decade of life. And again, you see here the putative autoantigens, the prevalence of concurrent immune diseases, and the other characteristics that we've all talked about. Histologically, it is very characteristic. Again, autoimmune hepatitis is represented histologically by interface hepatitis or piecemeal necrosis. You can have collapse of the liver lobules because of inflammation and hepatocellular destruction. Inflammation with lymphocytes and especially plasma cells can be diagnostic, but there are other inflammatory cells, such as EOs, and even in some cases neutrophils, which can invade. The brisk inflammatory response leads to hepatocellular rosette formation, and ultimately necrosis leads to fibrosis and cirrhosis. And steatosis tends to be absent in these patients, as do portal lymphoid aggregates. So when you see steatosis, one starts to wonder about, could this be another disease altogether? Because steatosis is not a characteristic finding in most patients histopathologically with AIH. And here is a typical portal area. You can see it's pretty hard to see the individual structures, but you see a large amount of lymphocytes. And one of the things is, normally when you see a portal area, there would be all portal areas contain some inflammatory cells, and there's usually a pretty good demarcation between the hepatocellular lobule and the portal area. But here you see no what we call limiting plate. You just see inflammation that's carrying well into the parenchyma. And so this is called invasion of the limiting plate. You don't see that demarcation. This is very characteristic of autoimmune hepatitis. And here you see, again, looking at the lobule, this is not a portal area, this is the lobule, and you can see the very dark staining cells here. It's difficult to see the cell type, but these are clearly chronic inflammatory cells invading the parenchyma. And here is our friend, here is our friend, the plasma cell. You should recognize plasma cells. They are diagnostic in patients with AIH. Here's a whole group of them. Notice that they have this pinkish purple cytoplasm, fairly light, with a very dark, large nucleus, always pushed to one side. Here's one, here's another, here's another, here's another, here's another. So this plasmacytic infiltrate is very, very characteristic. And if you see a biopsy of autoimmune hepatitis on the boards, they'll always have lots of plasma cells. Again, because they are so characteristic of the disorder. So the prognostic indices that one uses in order to determine, again, what the likelihood of progression will be and how you're going to treat these patients include both the AST and ALT levels, as well as the immunoglobulin level. And histologically, do we have piecemeal necrosis? Do we have bridging or multilobular necrosis and fibrosis? And is frank cirrhosis developing or has developed? In severe disease, to go over it again, this is characterized by an ALT greater than 10 times the upper limit of normal, or an AST greater than 5 times the upper limit of normal, plus an IgG greater than twice the limit of normal. Associated with bridging necrosis, a collapse of the hepatocellular lobule. Again, the DRB1 subtype is shown here, and the highest risk group appears to be African American males. In this group, mortality untreated is very high, and it's 90% at 10 years if patients are not treated. Patients with mild to moderate disease have an ALT less than 10 times the upper limit of normal, with a lower level of IgG, with periportal hepatitis without invasion of the parenchyma to a great extent. Again, a specific HLA subtype. And these patients will have a 10% 10-year mortality, although they run a much higher risk of developing cirrhosis. Those patients who already have piecemeal necrosis or interface hepatitis will have a 17% risk of cirrhosis at 5 years. And if it doesn't go beyond this, they may have a normal survival if they don't develop cirrhosis, obviously. The bridging or multilobular necrosis patients will have an 82% risk of cirrhosis at 5 years untreated, with a 45% 5-year mortality. And patients with cirrhosis will have a 60% 5-year mortality. Now, I caution you that this is all from adult data. In pediatrics, obviously, we don't ask whether this is moderate or severe disease before we treat. We want to know it, but we are going to treat all of these patients. The overall goals of treatment are to induce remission first and foremost, prevent disease progression, minimize the relapse of disease, improve survival, and of course, we want to minimize medication side effects. So when you see a patient who has some characteristics that are consistent with autoimmune hepatitis, should we treat immediately or monitor? And again, most of this data is from adult subjects. In adults, the absolute treatment indications include patients who have pronounced symptoms or whose disease appears to be progressing. Again, the laboratory is greater than 10 times the upper limit of normal, or the AST greater than 5 times, plus an immunoglobulin greater than twice normal. And if they have bridging necrosis or multilobular necrosis, that's an absolute indication for treatment. What about the relative treatment indications? And again, I would caution you, these are relative treatment indications in adults. We would also consider them to be absolute indications in children. And that would include patients with mild symptoms, AST levels and immunoglobulin levels that are not as quite as high, and interface hepatitis and active cirrhosis. So again, in adults with mild symptoms, even though they have laboratory values that are in the treatment range, there would be some option whether to follow them or to treat. But I think any child or adolescent who presents with these characteristics, one would treat as well. But what about no treatment?
What would be the rationale for not treating an adult with cirrhosis? Because is it just that the adult is someone who's like very elderly or something? I don't understand.
Yeah, it all depends. It all depends. Yeah, this is these are relative treatment indications. Again, remember that a lot depends upon the nature. Some patients can have active cirrhosis, but it can have minimal activity.
I see.
Depending upon what their scoring is. Again, this is in adults, so I can't imagine any patient that we would encounter that we would not treat.
Right. Thank you.
So again, what really the question we would have to ask in that regard, Bryce, is who do you choose not to treat? What about if your patient is asymptomatic? All right. Well, how do you know if a patient is intolerant to prednisone and azathioprine? Only if they've had experience with the drugs. But patients who have an AST less than 3 times the upper limit of normal, or who have pre-existing cytopenia, because again, the drugs that we treat will further lower the white blood cell count. And again, patients who have inactive or compensated cirrhosis. What is inactive cirrhosis? Well, it's the presence of cirrhotic nodules without any ongoing inflammation that would further the clinical scenario. Or patients who have portal hepatitis, or inflammation is limited to the porta hepatis without invasion of the limiting plate. This becomes, I think, more of an issue when you do a follow-up biopsy on patients and are trying to figure out whether you should be withdrawing therapy. It's a question that really is at sort of at the back end, not in the beginning of therapy. The immunosuppressive therapy really hasn't changed. It involves in our patient population the combination of prednisone and azathioprine, and again, the length of therapy will vary from clinician to clinician. This was what was recommended by Shia. This is early in the 21st century. And starting azathioprine 50 milligrams per day with a fairly rapidly tapering dose of prednisone over a period of 4 to 6 weeks. The alternative would be prednisone alone. Again, if you have a patient with cytopenia, one might choose to use prednisone alone rather than including azathioprine. The treatment endpoints are difficult. Obviously, you want to have disease remission. You want to avoid relapse after treatment withdrawal. Treatment failure is an endpoint. An incomplete response is an endpoint, and drug toxicity is an endpoint. So you have to be able to deal with all of these endpoints in deciding what to do. In our patient population, generally, disease remission is fairly rapidly achieved through a combination of prednisone and azathioprine. But relapse after treatment withdrawal is also a common problem. I've seen very few patients where treatment has failed, although it does occur. Many patients may have an incomplete response, which may warrant either increased therapy or a different drug approach. And then drug toxicity is something that we all worry about. Disease remission is characterized by a patient being asymptomatic, a normalization or near normalization of your aminotransferases, a normalization of your immunoglobulin G and your bilirubin, minimal or no hepatic inflammation, and when hepatic inflammation is present, it's limited to the porta hepatis. And so what is disease remission statistically? Again, in adult patients, 65% by 18 months and 80% by 3 years following the initiation of therapy. And the 10-year survival of patients who go into remission is 90%. How do we characterize relapse after drug withdrawal? Obviously, an elevation in your aminotransferases, an elevation in your IgG, recurrent inflammation. The risk of relapse is 50% at 6 months and 70% of 3 years following withdrawal of therapy. When patients relapse, you start them off on the same regimen as for naive patients. Again, the combination of prednisone and azathioprine. These patients, however, will stay on low-dose prednisone and or azathioprine even beyond when they appear to go into remission the second time. Of these patients who relapse, eventually almost half of them will achieve a sustained remission off medications after 10 years. Treatment failures are characterized by worsening symptoms, an increase in the AST and bilirubin, progressive necroinflammatory activity, other signs of liver failure, and these patients will require high-dose immunosuppressive therapy. High-dose immunosuppression would be up to 60 milligrams of prednisone per day. Again, there's no evidence that greater than 60 milligrams is going to give you anything but increased side effects. One can also choose to use a lower dose of prednisone, but azathioprine 150 milligrams daily, and you will recommend this therapy for at least 1 month before tapering. And 70% of these patients will develop biochemical and clinical improvement within 2 years. And 20% will resolve their inflammatory activity. However, these are the patients who are more likely to require, obviously, long-term therapy and ultimately a liver transplantation. Sometimes you have patients who have an incomplete response where there's an improvement in all parameters, but they fail to satisfy remission criteria. Remission is unlikely in adults if it cannot be obtained within 3 years of the initiation of drug therapy, and these patients are given long-term low-dose prednisone and or azathioprine to control symptoms and to try to maintain the AST level to less than 5 times the upper limit of normal. Drug toxicity is most associated, obviously, with long-term steroid therapy, save one of these toxicities. Intolerable symptoms or obesity, osteoporosis and fractures, diabetes, and cytopenia, of course, is the number one concern of patients who are on any of the thiopurines. And remember that lowering the white blood cell count to a level of about 3,000 to 3,500 is a treatment goal. We would not, if you have a patient on azathioprine or any of the thiopurines, and they come in with a white count of 8,000 or 10,000, you're probably not giving them sufficient drug. Azathioprine-induced hepatotoxicity, of course, does occur and can be a problem. And when one develops drug toxicity, one either has to reduce, withdraw, or change the immunosuppressive medication. So the alternative medications are numerous, including MMF, cyclosporin, tacrolimus. Tacrolimus may be the first choice for a secondary therapy in children. Budesonide, I've never used it. I've not been impressed with its success when I have used it. Methotrexate and Cytoxan. All of these drugs have been tried. What are the indications for liver transplantation? Obviously, patients who develop complications of portal hypertension that can't be controlled, obviously carcinoma, end-stage liver disease, and then fulminant liver disease. And I know Dr. Rabinowitz and I have been involved in several patients who presented with fulminant liver disease secondary to AIH. Fortunately, as I recall, these patients responded to high-dose steroid therapy. But when they present with fulminant hepatic failure, again, one has to refer them immediately to a transplant center and let them continue the high-dose steroid therapy before deciding on whether or not a transplant is necessary. The problem with doing transplant in these patients is while there is a very high percentage, 80 to 90%, have a graft survival at 5 years, they can develop autoimmune hepatitis in the transplanted liver, up to 40%. And there's a higher rate of both acute and chronic rejection in these patients, not surprisingly, for patients with a fulminant autoimmune disease. So let's look at a case history. We have a 14-year-old female with 2 weeks of fatigue, nausea and vomiting, and right upper quadrant pain. She presents with jaundice, epistaxis, lethargy, and confusion. Screening is negative, negative urine toxicology. Ultrasound shows no biliary pathology. Has a positive family history of type 1 diabetes and autoimmune thyroid disease. She's pale, confused, jaundiced. She has asterixis, fetor hepaticus, hepatomegaly, splenomegaly, and no Kaiser-Fleischer rings. Her workup shows a hemoglobin of 8.8, white count of 7,800, platelets of 400,000, sodium's a little low, BUN 22, creatinine is a little high for her age. Her AST is 1,000, ALT 560, low alkaline phosphatase, and a bilirubin of 12.8 over 8. All right. Ammonia is 95, albumin 2.8, total protein is 8.9. You see the PT is 18.5, PTT is 46, INR 1.8. ANA is 1 to 160, anti-smooth muscle is 1 to 80, anti-LKM is negative. Her IgA is anti-TTG positive. This is a real patient, by the way. Her alpha-1 antitrypsin is within normal limits. She has a ferritin of 510. There you see the iron, the TIBC, the copper, and the ceruloplasmin is 23. Is this a case of type 1 autoimmune hepatitis presenting with acute liver failure? Well, liver failure is more common among type 2, but has been reported in type 1. The prolonged INR and hypoalbuminemia is seen in 50% of patients with type 1 autoimmune hepatitis. This patient may not have cirrhosis, but has severe inflammation and central lobular necrosis. The ANA and AS anti-smooth muscle may be low titer or even absent initially and become positive post-therapy, and may only have anti-smooth muscle antibody positivity of presentation. Now, her ANA is 1 to 160, ASMA is positive, although weakly so. So, If one was going to say whether or not she had Wilson disease, what of these laboratory values is going to be most important?
The copper.
Alkaline phosphatase.
Alkaline phosphatase, what else? Not by itself.
If you're ruling out Wilson's disease, looking at the ceruloplasmin and copper.
Ceruloplasmin is normal.
The urinary copper?
You're going to do a 24-hour urinary copper? She may be dead after that if you don't treat her. If she got Wilson disease, right? She got
She also
liver
had
failure.
absence of Kaiser-Fleischer rings.
Okay. Okay. It's the alkaline phosphatase to total bilirubin ratio. All right. If that has a 94% sensitivity and 96% specificity. When the alkaline phosphatase to total bilirubin ratio is less than 4, that strongly suggests Wilson disease. And this is most important in a patient like this, because if this patient has Wilson disease, how are you going to treat her?
With the chelation?
Excuse me?
So either chelation or transplant. Those are the two.
There ain't no either or. Patient with fulminant liver failure presenting with Wilson disease goes to transplantation. So you have really to rely on this data, so again, it's if the alkaline phosphatase total bilirubin ratio is less than 4, the patient most likely has Wilson disease, and it's shown here. It's one of the few diagrams I keep putting up because it is so impressive. These are 3 groups of patients presenting with acute liver failure. To the left is acetaminophen-related liver failure. In the middle is non-acetaminophen liver failure, and to the right is Wilson disease liver failure. And look at this. There is no overlap, none at all. Patients with Wilson disease are a separate category in and of themselves when they present liver failure. They will all have this total bilirubin, alkaline phosphatase total bilirubin ratio less than 4. What about celiac disease? She had a positive TTG. Well, patients with celiac disease do have autoimmune liver disease in a low percentage, and this is an Italian study. The incidence of celiac disease and autoimmune hepatitis, 4% prevalence of celiac disease in 181 patients with autoimmune hepatitis. Keep in mind that patients with one autoimmune disease tend to have another autoimmune disease. In most of these patients, the diagnosis of celiac disease precedes that of autoimmune hepatitis. And some develop autoimmune hepatitis even after a few months on a gluten-free diet. And some of these patients were also found to have IgA deficiency. But again, patients with autoimmune hepatitis at least should be screened for the possibility of other autoimmune diseases. Get a TTG, get anti-thyroid antibodies. Simple blood test, you're going to draw bloods anyway. It's worthwhile to evaluate them for other more common autoimmune diseases. Interestingly, 8 of 185 Finnish patients undergoing liver transplantation had celiac disease. 6 13 to 36-month Swedish children with celiac disease had liver failure. 4 to 6 with elevated IgG, but only 1 out of 6 had positive autoantibodies. A third of them required transplant. They all had portal inflammation, but only 1 out of 6 with interface hepatitis. So it's hard to say whether these patients did have, in fact, autoimmune hepatitis. But again, patients with an upregulated immune system reacting against self is likely going to have manifestations in multiple organs. So what are the take-home points? Autoimmune hepatitis is a chronic hepatocellular disease of unknown etiology. Its clinical presentation is variable. Its diagnosis is based on serologies, common laboratory liver chemistries, gamma globulin, and histology. Immunosuppression is the mainstay of treatment. And again, you will often need to tailor your therapy based on the treatment endpoints that we've discussed. So we have a couple of questions. Would someone like to read the first?
Sure. A previously healthy 40-year-old woman presents with fatigue and dark urine for 2 weeks. There is no history of significant alcohol or drug use. Physical exam is remarkable for jaundice and tender hepatomegaly. Labs are notable for AST 1000, ALT 1500, and alkaline phosphatase of 350. The total bilirubin is 10 milligrams per deciliter, and the INR is 1.3. ASMA is positive to 1 in 320, and IgG is twice normal. Liver ultrasound reveals only hepatomegaly. What findings would be found on liver biopsy? A. Perivenular neutrophil inflammation with ballooned hepatocytes and Mallory bodies. B. Infiltration of portal tracts with lymphocytes and plasma cells, interface hepatitis, piecemeal necrosis along the limiting plate. C. Infiltration of portal tracts with destruction of interlobular bile ducts. D. Periportal and lobular non-caseating granulomas. Or E. Ground glass hepatocytes and Councilman bodies. And do you want me to try to answer? Because I think I know the answer.
What's the answer?
I think the answer is B as in Bravo, because of the lymphoplasmacytic infiltrated interface hepatitis.
Correct. All right. Now, you should all know what all of these are. Right? I'm not going to tell you, but all of these have are of significance in our patient population. Next one. Someone else want to go?
Yeah, I can read this.
Okay.
Which one of the following statements about prognostic factors and autoimmune hepatitis is true? A. Mild periportal hepatitis is associated with 90% mortality at 10 years without treatment. B. 60% of patients die within 6 months of diagnosis. C. AST greater than 10 times the upper limit of normal or greater than 5 times the upper limit of normal with gamma globulins greater than 2 times the upper limit of normal are associated with 90% mortality at 10 years without treatment. D. Bridging necrosis is associated with a favorable prognosis. And E. Young patients are less likely to go to transplant when compared to older patients. And I think I know the answer to this question. So I think C. AST greater than 10 times the upper limit of normal is associated with a poor prognosis.
That's it. Next one.
Mariam, you want to go?
Yes. A 12-year-old female presents with malaise, fatigue, and myalgia. She mentioned that her stools are lighter color than normal. Physical examination is remarkable for jaundice and a liver edge 2 fingers breadth below the right costal margin. Her laboratory evaluation reveals a total bilirubin of 13.1 mg per dl, AST of 23,000 units per liter, and ALT of 3124 and INR of 1.4. Type 2 autoimmune hepatitis is suspected. What laboratory test is appropriate? ANA and anti-smooth muscle antibody, anti-mitochondrial antibody, and total lipid profile antibodies to soluble liver antigen, serum IgM, anti-liver microsomal antibodies.
And the answer is?
A.
What's the last sentence before which laboratory?
Oh, the
test is
2 for
appropriate?
type 2. It's the last one.
Yes. So again, when you're reading a question, read the whole question. Obviously type 1 is more common than type 2, but this one says type 2 is suspected. Now you're going to get an ANA and an anti-smooth muscle antibody anyway, but in this case you can only choose one. Type 2 is suspected. You're going to do an anti-LKN.
Oh, I can read it again. Which one of the following is an absolute indication for treatment with steroids and azathioprine? A, cirrhosis with minimal activity. B, bridging and multilobular necrosis. C, ALT less than 3 times the upper limit of normal. D, portal inflammation. And E, mild symptoms. So it's not mild symptoms. It's not ALT less than 3 times. It's not portal inflammation. I'm confused between E, A, D, cirrhosis with minimal activity versus bridging and multilobular necrosis. I'm going to go with B, bridging.
Yeah, cirrhosis with minimal activity you would not necessarily treat.
Gotcha.
A 28-year-old female presents for evaluation of abnormal liver-associated enzymes. Overall, she feels well and the physical exam is unremarkable. Labs reveal AST of 2124, ALT of 2256, ANA and ASMA are positive. Liver biopsy shows panlobular necrosis. Which one of the following is an appropriate next step? A, begin azathioprine as monotherapy at 50 milligrams daily until remission achieved. B, begin cyclosporin 100 milligrams twice daily in combination with mycophenolate 500 milligrams twice daily. C, refer the patient for liver transplant evaluation. D, begin prednisone 30 milligrams daily in combination with azathioprine 50 milligrams daily. E, repeat liver-associated enzymes in 3 to 4 weeks prior to making treatment decisions. I don't think we do monotherapy for azathioprine. She doesn't seem to be at the point of needing a liver transplant. D is a fairly hefty regimen. I think it's E is an echo, but if not, then my guess would be D. It was D. Okay.
She's got autoimmune hepatitis. What are you waiting for?
Right. It's not really going to get better in 3 to 4 weeks. It's just, oh yeah, right, because we're just starting it off. That's why we're starting with 30 milligrams of prednisone. We're going to taper it down, right?
Yeah.
Okay, thank you.
Last one. Anybody?
I can just read it. Which treatment is most appropriate for patients that have worsening liver enzymes despite standard treatment with steroids? Which treatment is most appropriate for patients that have worsening liver enzymes despite standard treatment with steroids and azathioprine? A, increase prednisone to 60 milligram daily or to 30 milligram daily in combination with azathioprine 150 milligram daily for at least 1 month. B, refer immediately for liver transplant eval. C, add tacrolimus 2 milligram daily to prednisone and azathioprine. D, stop prednisone and start azathioprine, mycophenolate, and tacrolimus 1 milligram. And then E, continue steroids and azathioprine at the same dose and repeat liver enzymes in 6 weeks. Is it B, refer immediately for transplant eval? Increase the steroid. Okay.
All right. So you've got a treatment failure. All right. Treatment failure. The first step would be to increase therapy. All right.
Got it. That makes sense.